Just from a background standpoint, it is capnography's role in providing a safety net during procedural sedation in the emergency department is what drove its introduction into the emergency department. I'm very thankful for that because now it's allowed us to use the technology for many other things while providing safety for this primary intervention. So while EMS has been an avid adopter of capnography for many roles, it's the sedated patient where very few of us have true protocols or use it in that patient. Every day when we take care of injured patients or sick patients, we will often give them medications that can cause respiratory depression and respiratory problems. We monitor them right now only with pulse oximetry, but that can lag the true problem by several minutes. What we know from the emergency department is that the use of capnography can decrease the respiratory complications, can identify that hypoxia may occur anywhere from a minute to 6 minutes ahead of time, which allows us to provide even more safety to our patients as we care for them to prevent an unintended consequence. So if you have a patient that is in an unstable heart rhythm, ventricular tachycardia, and they need to be cardioverted, but you have a little bit of time because they're quasi-stable that you can sedate them first with Versed. Many protocols say to put them on pulse oximetry and to sedate them until they appear drowsy or their speech is slurred, and then provide the cardioversion to correct their underlying heart rhythm. That generally works, but of course the medication lasts a lot longer. We tend to be satisfied that the emergency has been taken care of when the cardioversion is done, but forget that we've given them sedative medications, and we may under-recognize the respiratory side effects of that downstream. By putting the patient on capnography, we can monitor their total respiratory status, not just their oxygenation, and make sure that we are safely protecting this patient. There are some who may need rescue breathing or repositioning after the procedure until the sedation wears off to keep them from having a second complication. I see capnography as a wonderful tool that can be applied in many situations, much like we use 12-lead EKGs. We were somewhat slow adopters and then started to use it only for ST elevation MI. But we can look at it and learn a lot more about the patient depending on the clinical situation. We have capnography now, and while its main use is for verification of endotracheal tube placement, we've got that technology that can be applied in many other clinical settings, so we should take advantage of that and learn in there might be roles in the dyspneic patient, in the diabetic and diabetic ketoacidosis patient, in the shock patient, in the sedated patient, in the seizure patient, in the trauma patient, in the head injured patient, that we can use the same tool and same technology in slightly different ways to provide a whole new level of care for our patients. I think it's silly that forever we have focused our vital signs only on heart rate, respiratory rate, which most of us make up anyway, blood pressure and oxygen saturation, and been ignoring ventilation.